science book, which is not thrilling. It's anatomy. I like the case conferences. I think they're more interesting, but for your benefit. And the other thing I'd like you to do is I really, really, really want you to go onto Retina University and register. And if you have trouble, because I put a quiz up already for this lecture. And I think you'll learn it better if you do the quiz. And the quiz is really hard. So I might make it so I have it now so you get the feedback at the end of the quiz, but I think I'm going to go and change the settings so you can get the feedback after each question. And that way you learn more, because it's not really for the score, it's just so you learn it. But if you're not tested on it, you don't learn it as much. So for this is going back for our part of the anatomy, we don't care about the cornea or the lens. So we're going to do vitreous, retina, RP, Brooks membrane, choroid, and sclera. And so starting with the vitreous has made up of type 2 collagen fibers and hyaluronic acid, which you need to know that. And the type 2 collagen is of some interest biochemically because it's the same collagen in your joints. So maybe one of the reasons why the eye and the joints behave so similarly with the arthritis. And your eye is actually designed like a ball and socket joint, if you think about it. And the firm attachments are the vitreous base, the lens capsule, retinal vessels, optic nerve, and the macula. All of which are important for various pathological things. I'm going to do a little bit of clinical stuff, but mostly just the anatomy, so you'll learn it. One thing to know is when you're looking for retinal tears, it should be impossible to get a retinal tear within the vitreous base because there's no traction there. It's where the vitreous attaches, posterior to the vitreous base, where you get a tear. So sometimes you'll be looking way out in the periphery and you shouldn't get a tear way out. So this is an example of vitreomacular traction. This is not unlike the case we had in conference, except the outer retina is not distorted. And this one just released in 4 months. So, and the patient was symptomatic, but not too bad. So that shows the vitreoretinal adhesion at the macula. This is a diabetic with a combined PVR, PDR retinal detachment, which if you talk to experts in retina, they'll say that this is probably an eye that should just be left alone because these are almost impossible to fix. But it does show the attachments over the vessels nicely. So you can kind of see where it's attached, it's attached to the nerve, attached to the vessels. This is a subretinal fibrotic band, and those are prognostically not good. And then there's a bunch of eponyms with the vitreous, which I think maybe someone can come up with a good mnemonic for these. But there's, so eponyms go way back in medicine. A lot of times you didn't know what the disease was, so you named it for somebody to honor them. And they allow you to know what you're talking about. So there's a ligament of Weiger, which is where the anterior highlight attaches to the lens capsule. There's Berger space, which is bordered by the ligament of Weiger, and that's just the pocket behind the lens. And that's all important for you guys for when you break capsule, if you ever break capsule. And then there's this space of Mardigioni, and I'm pretty sure these were all in your book, but they might not have all been, which is in front of the optic nerve. Cloquet's canal, you kind of need to know it's through the middle of the vitreous. Mittendorf dot is a circular opacity in the back of the lens capsule, which is where the hyaloid already had attached, but it's not, those are never really visually significant. And then a Bergmeister papilla is a little tuft. So I have them here on a diagram, and you'll see there's a test question on your quiz, and there's boxes where you drag it. Just kind of pick the box nearest to where you're trying to get it. It's not that well written. Don't get too frustrated. So the ligament of Weiger, it's right there around the lens. I did this animation thing because this you can't point to the screen. So the ligament of Weiger, it's where it attaches at the edge of the lens. Berger space is that space in the middle, and then the space of Mardigioni is right in front of the optic nerve. Cloquet's canal is going through the middle. Mittendorf dots on the back of the lens, and the Bergmeister papilla is a little thing coming off the optic nerve. So that's all your vitreous eponyms. And, I think the ones you'll see maybe are Cloquet's canal and Bergmeister papilla, and maybe a Mittendorf dot, because sometimes people will do a cataract evaluation and see that. So that's all I'm going to talk about the vitreous. Anybody got any vitreous I want to talk about? There's a guy, Seabag, who wrote a book on the vitreous, which I bought, which doesn't, people can talk so much about the vitreous, and vitrectomies for floaters you can talk about later. So then we're getting to the retina. So if you look at the retina face on, the macula is the center 5.5 millimeters, which is anatomically where there's 2 or more ganglion cells. So you need, that's super important. And half of all retinal ganglion cells are in the macula. So that's why the ganglion scans are going to become important for following glaucoma. And that's the macula. Someone told me it's the size of a nickel. I've never measured a nickel, but he tells his patients the size of a nickel. The near periphery is a 1.5 millimeter ring outside the macula. I've never used that term, but it's in your book, so you're stuck with it. And then the equatorial retina is all the rest of the retina. Oh, and you know, we didn't talk, the case Chris was talking about, those were equatorial drusen. I forgot to talk about that. The patient with the macular hole, the yellow spots out the side were equatorial drusen, which are super common, and they can be striking. And sometimes we talk about the equatorial retina is also a zone where you're prone to miss things on exam. So when you examine a patient, you typically, what I do, and what most of us do, is look at the macula with the slit lamp, and then you put on the headset and look at the periphery, and sometimes that equatorial region you can miss. So you have to sort of make a habit of going back and forth a little bit. The peripheral retina is outside of this picture, but it's the area, the posterior border of the vitreous base to the ora serrata. And then I think it's actually a little bit farther back than that, from the anterior to the equator to the ora serrata, and the ora serrata is way out. And then the macula anatomy is what you can see on the OCT scan or in histopathological scans. So going actually from the bottom to the top is easier for me. The umbo is the very small spot where the light reflex is. When you look, it's tiny. And then the foveola is smaller than the foveolae vascular zone. It's just a little part in the middle. And then the fovea is where it starts to smooth in, where it starts to dip. And the fovea has only cones. And interesting to know is the fovea has 140,000 cones per millimeter squared. And this comes up because the more the retinal prosthesis gets advanced, the more your patients are going to be asking for it. And I have patients with macular degeneration asking me about getting a retinal prosthesis. And even at 140,000 cones per millimeter squared, nothing comes close to that. So even if you've lost 90% of your cones, you're still going to beat the retinal prosthesis. And then the parafovea, I hadn't heard of until I read your book. And it's that area that's the thickest part next to the fovea. So it's where the thickness kind of maxes out, like if you were climbing a hill. And it's a very small area. And then that's a parafovea. Then the parafovea is everything outside of that. And someone asked me this question decades ago about the paraphobia and paraphobia, because they got asked it on their, not for residency, for a certified ophthalmic technician. They were asking about the difference between the and I said, I have no idea. So now you know what it is. So the paraphobia is the thickest and the paraphobia is adjacent to that. And then the layers of the retina are important to know. And some of these slides are from my brother and some are from Curtis Margot, some of the histopathology. So I dug them up. I try not to use the internet slides because I don't want to get yelled at about copyright. So going from the inside to the outside on a histopath slide, you've got the internal limiting membrane, which is the thin membrane. It's the basement. It's a true basement membrane. It's the footplate of the Mueller cells. And you can peel it off the retina if you want to, if you stain it, or if you don't stain it. The nerve fiber layer is the next layer in, and that's all of the axons from the ganglion cells, and it becomes the optic nerve. The ganglion cell layer is your first nuclear layer when you're going from the inside to the outside, and that's what gathers up all the images. And then the interplexiform is your communication between the middle of the retina and the ganglion, and then the, where are we at? The interplexiform internuclear layer is all your intermediate neurons, which are the, I think I have the next slide, horizontal cells and bipolar cells. And then the outer plexiform is the connection between the photoreceptors and the intermediate neurons, and then you've got your photoreceptors. You've got the outer nuclear and the photoreceptors, the rods and cones. Excuse me, and then the RPs, the pigment, and then the choriocapillaris. So those are all your layers. You have any questions about that? And the neat thing now is you can see those on OCT. So this didn't used to be such a big deal, but when you look at an OCT, I encourage you to think retina. Think about the retinal layers, and it can help some. So here we go. So photoreceptors. So the cones are for highlight, which is photopic. So you'll hear, you guys might not have heard, but all the ophthalmology's got a million terms. Photopics for the light, scotopics for the dark, and mesopic is where both work. So high levels of light are photopic, rods are low levels of light, and they can respond to a single photon. Cones are color vision, and rods are black and white. So you'll notice at night you don't see color when your eyes are adapted, and they're very dark in the light cones. Squirrels have only cones. It's an interesting little stupid fact. And high spatial acuity for the cones. Rods are not very, you can't see that much with rods. The fovea's got 140,000 cones per millimeter squared. The rods have 160,000 rods per millimeter squared, where it's the densest. And the rods are densest 20 degrees from fixation. Does anybody know what phenomenon that's? Does anybody experience the rods being off center when they do anything? When you look up at the night sky. So if you notice, when you look at the night sky, you'll see stars that are small, and then when you look at them, they disappear. So it's a little, that's your rods work. 90% of cones are, even this is the kind of stuff, when I study for the boards, I look for things that don't make sense. When I studied, I still have to take them. I was the first group that had to recertify. But we know that it's super easy recertifying. But this is one of the things, I would put this, if I were doing questions, I would put this on the boards. 90% of the cones are outside the fovea. So even though the cones are in the fovea, it's just one of those goofy little things that was right out of your book. And the rods are 20 degrees from fixation. Also, the cones have a 1-to-1 synapse in certain areas with midget bipolar cells, and there's about 6 million cones, and there's about 120 million rods cells in your eye. And when you get out to the periphery, and this is that case we saw. This was a patient with retinitis pigmentosa, and that's an example of a disease where you've got your rods damaged. And this is a case of, you want to shout it out? Where there's white spots in the retina, and then the abnormal fluorescence. This is autofluorescence. It's muted. So you got autofluorescence OCT, autofluorescence ICG, and the OCT, and that's an outer. So those are all diseases of the outer retina, which they give you typically a shimmering scotoma, and so it's nice to know where the disease is. So we saw central artery occlusion, that's inner retina, which somewhere, and then the outer retina is the other diseases. Phototransduction is not in the anatomy lecture. It's not in the anatomy chapter, but it's one of your other books, so I looked it up. So, because I think it's interesting. So there's a couple of things I find interesting about phototransduction. The photons plus the retinal, 11 cis retinal switches to all trans retinol. And that's what kicks off the whole cascade, so you need to know that you go to all trans. The GMP and sodium channels opening I don't think is as important. But one thing that's interesting is that one of the key enzymes in the phototransduction cascade is phosphodiesterase. It's subtype 6. And does everybody know why that particular enzyme is important? What drugs inhibit phosphodiesterase?
No.
Viagra and Cialis and those. So, and those inhibit phosphodiesterase type 5, but they do cross-react. Supposedly Viagra cross-reacts more than Cialis. So if you have a patient that really needs to be on that. I tend to ask people to back off on those medicines when they have certain retinal diseases. And for retinal dystrophies, they probably should avoid them. And then the other thing I think we're talking about later is the on-center, off-center design of the retina, which is weird. And then the other thing that's interesting about the visual cycle is there's one visual cycle that's used by the rods, and that's the visual cycle that cycles through the RPE. So the RPE visual cycle, rods and cones both reset the retina. When the cis goes to the trans, it has to be reset to cis and pushed back up. And the rods and cones both use the RPE, but the cones can actually use the Mueller cells. So there's a retinal phototransduction cascade that, or visual cycle. It's not that. So there's a visual cycle that the retinal can use, and I think I think, and I'm not positive, that's one of the reasons the macular degeneration patients have so much trouble with night vision. I think part of it's just that they lose their rods, and that's probably most of it. The retina's just going away. But I think part of it is that in the daytime, you've got even if your RPE is all diseased, your Mueller cells can do your visual cycle. Whereas at night, your rods can't use the Mueller cells, they have to use the retinal cells, but I'm not sure that's exactly correct. But one of the symptoms you'll see, which I see at least once a month, is someone with macular degeneration who wakes up at night and they get a dark spot in their vision. And I always tell the patient with macular degeneration is you got to monitor your vision in regular lighting, because in dim lighting you see all sorts of weird stuff, and I think some of it has to do with the visual cycle. All right, so the photoreceptors are your first order neurons. Your second order neurons are the bipolar, horizontal, and amacrine cells. And what they do is they connect the photoreceptors to the ganglion cells. And remember, you have 125 or about 125 million photoreceptors and only 1 million ganglion cells. So the retina does a bunch of processing. So I always tell people the retina truly is like brain tissue. The bipolar cells connect the photoreceptors to the ganglion cells. They have graded potentials, which is interesting, and I believe is in your book. I know that might not be, but I think it's still interesting. So the photoreceptors and the second order neurons don't do action potentials. They do graded potentials. So what happens is as they receive neurotransmitters, they kind of up and down. It's very much like an analog system. So it can do more processing. And then the only cell in the retina that does an action potential is the ganglion cells. So what they do is they all kind of nudge it this way, nudge it that way, and then when it gets over thing, it fires. Your horizontal cells do lateral inhibition, and they do that sort of center surround thing where they help figure out contrast. So the ganglion cell, the way the retina works is looking more at edges, not at fields. And then the amacrine cells, I don't understand it. They do lateral inhibition of the axons, and they help improve signal transduction, and they dampen noise. So they work more on the ganglion cells to sort of adjust things. Hold on. I think okay. So then this is an example of it. This is one of the only things I know that damages the middle retina, and it's got a disorganization of the retinal inner layers. This is a patient of mine who had a branch retinal vein occlusion, had really severe macular edema. Back in, I saw her back a couple months ago, or actually last month, and even though her retina had resumed a normal shape, like if you look at that on the OCT map, it's going to look like a normal map. Her vision's still not, she still can't see the chart. And that's because all the inner retina. And the other thing about these pictures is the outer retina doesn't look that bad. It doesn't look great, but you can actually see a little bit of photoreceptors, and you can see the nerve fibers fine. So she's got a middle retinal problem. So you do need your middle retina. I have to say the middle retina is pretty resilient. There's not a lot of diseases. You can have a lot happen to your retina, and the middle retina is pretty tough.
Any intervention from June to September in 17 there?
What's that?
Did you do anything for her in the first two slides?
Yes, I think I gave her shots.
Okay.
And this is the kind of patient, you see this in, I don't know how many, 10-20% of vein occlusions, where you give them shots, the macula dries out, their vision doesn't get any better. And what I'll do is if they're dried out for, sometimes it can take 3 to 6 months to get better, but if you have it dry for 6 months and the vision's still 2200 or 5200, like this patient, it's not, I don't think it's worth continuing treatment. So I usually stop. And then your ganglion cells are the third order neurons, and these are the ones that connect all the way back to your brain. So the axons of the ganglion cells turn into the optic nerve, the optic chiasm, and the optic tract. They have true action potentials. They fire, they become myelinated. This is new since I was young. Some of the ganglion cells are photosensitive. So there's so some of your ganglion cells mostly, so you have photoreceptors, but there's some ganglion cells that seem to affect your circadian rhythms. These were discovered 5 or 10 years ago, but they're in your book. And so anyway, and they probably have to do with the pupillary light reflex. And there's about 1 million ganglion cells compared to 125 million photoreceptors. The fovea has, on average, about 1 ganglion cell for every 5 photoreceptors. In the far periphery, it can be 1 ganglion cells per 1,000 photoreceptors. So that's why people sometimes, it's confusing to a non-ophthalmologist, I think, to understand why, when you've got a macular lesion, you can't just use another part of the retina. But the fact is that the macula is special. It's got a lot more. It's not so much at the there's so many more photoreceptors as the ganglion cells, or there's a lot more ganglion cells there. And then this is the receptive field thing, which always confused me, and I spent some time trying to unconfuse myself. And so the way the ganglion cells work, which is true of any sensory nerve, is any sensory nerve in your body has a receptive field, which is the field which it senses. So if you have like a pain fiber, you pinch yourself here, that fiber is not going to go off in your ear. And the same thing's true of the ganglion cell. So a receptive field is if you take a ganglion cell, point A in the retina, and you shine a light somewhere, it either fires or doesn't fire. And the receptive fields become bigger the farther out the ganglion cells are. There's a center surround ganglion cell receptive field. And that's if you picture a disc in the center with a concentric ring around it. And the way they work is there's on-center and off-center ones, so that when you shine a stimulus, if it's a donut, like if you shine a light in the middle of the donut, it'll fire, or if you shine a light on the outer part of the donut, it doesn't fire. So those are the receptive fields. In this grid illusion, if you look at it, it's kind of something to look at. I have it in my office waiting room. Is a scintillating grid illusion, which probably has something to do with the center surround design of the retina. There's not a lot on why your retina is designed this way. I think there's two reasons why you have the center surround. So your ganglion cells are not like a digital camera. So if you project an image of a sailboat on your ganglion cells, they don't reproduce the image on your retina. Your photoreceptors reproduce the image of the sailboat, but your ganglion cells don't take that back to your brain. Your ganglion cells just take the edges. So probably one reason is it's more efficient. So for example, if you're looking at the blue slide, all the areas of blue require absolutely no processing. All you're processing is the edges. So you're probably processing a lot less. The other one, which I didn't read about anywhere, but I think maybe just because I didn't do enough reading, is probably the way the visual system evolved. And if you look way back, I was watching some National Geographic or maybe Planet Earth, and they were talking about the very early photoreceptors in, I think it was jellyfish. And there are some jellyfish that could sense light and dark moving over them. And so I think probably in the early days of photoreceptor development, all you needed to sense was something moving, and that was bad, and you had to get out of there and run somewhere else. And so I think our ganglion, so our receptors, which makes it a little bit challenging for strategies to regenerate the retina. Because there was an interesting paper presented probably a decade ago now, because I'm getting so old, where there was someone figured out how to make your ganglion cells into photoreceptors, which was pretty cool. They did a biochemical manipulation in rats of ganglion. So you can do that. You can inject something in, it turns them into receptors, and they fire with receptors, but it's hard to say what kind of vision you would get, because your ganglion cells are not photoreceptors, and they got a light reflex in animals. Any questions about receptive fields? It's really good. So anyway, that's a receptive field. And then this is an example of a ganglion cell disease. This is not the patient we had today, but this is the central artery occlusion. And you can see right where the ganglion cells are. Now the central artery occlusions, block the circulation to the whole inner retina, throughout the retina, not just in the macula, but you see it in the macula because that's where you have more ganglion cells. So you get more. So even though the entire ganglion cell layer is swollen, because you only have one ganglion cell in the periphery, it doesn't turn the retina white. But where you have maybe 5 or 10 or 20 or 30 ganglion cells in the macula, they're all swelled up and it turns white.
Do you oftentimes see better vision in the periphery? Or is that just
They do get their, most patients with central artery occlusions get their peripheral vision back.
And what do you make of that?
I think it's probably the nerve fiber. I think it's probably where the retina is thinnest, there's more reversible damage because the choroid gives them perfusion. We had a really cool case about 10 or 15 years ago that I wanted somebody to publish. It was a patient with advanced glaucoma who got a central artery occlusion and had almost no damage. And I think it was because their ganglion cell layer was wiped out. So there was enough perfusion in their choroid to perfuse the whole what was left of their macula got enough perfusion from the choroid that even though they had a central artery occlusion, they had pretty good vision. So it was kind of an interesting case, I thought. And but a lot of central artery occlusions do get their peripheral vision back, and some get their central vision. So now we're getting onto retinal capillary. So there's a couple different retinal capillary networks you need to know. One is the radial peripapillary network, which feeds the nerve fiber layer, and that you'll be able to see on your OCT angiography when you get it, when you get maybe bigger fields. Excuse me. And I think that's one of the reasons you get cotton wool spots where you get them. Because in the radial peripapillary network is easy to remember because the retina is thicker, and you just need more capillaries. So what happens is any place the retina is thicker, you got more capillaries. And for the nerve fibers, as they're coming into the optic nerve, that's about this, the thing I drew on there is about the shape of the radial peripapillary network. They're slightly different from your other retinal capillaries. They're longer than the average capillary, and they have fewer anastomosis. And they're present in proportion of the RNFL thickness. And yeah, cotton wool spots are always clustered around the edges of that network. And I think that's one of the reasons we do that. And then in the macula, go ahead.
So that was just the distal end of the central retinal artery. As it branches out, it goes to all these capillary network and the shape of that shade there.
That's all the capillaries. Yeah, that's where the radial pericapillary. Those are all fed from retinal. It's a retinal. It's fed from the retinal arteries, and then you get the capillaries going back into the veins. But it's only present in that part of the retina, and it's present in the nerve fiber layer. So the different capillary networks are present at different depths. So this capillary network is just in the nerve fiber layer. It's the only one in the nerve fiber layer. The other ones are deeper. And these are the two we talk about with OCT angiography. You've got in your macula, your superficial capillary plexus and deep capillary plexus, and both of them are roughly 2 capillary networks thick. And you can see them on this slide. So if you look on the top and the bottom, not so well here, but here you can definitely see top and bottom. So you've got these 2 capillary networks sort of surrounding the nuclei, which is where there's probably more demand for energy. And then you have no capillary network other than these 2. So that's why I always find it interesting. When you look at the exudates we saw in that case, things tend to pile up not in these 2 layers. You tend to get edema in the so this is your internuclear layer in middle. This is your ganglion cell in internuclear layer. There's the outer nuclear layer is down here. I cropped it out, but the outer nuclear layer does not have a capillary network, and that's where you tend to get edema, which I think is kind of neat. And then so this is intercapillary here, superficial capillary and deep capillary. I always get confused because I always want to call it inner, but it's not. It's superficial capillary, deep capillary plexus. And then this is an example of paracentral acute middle maculopathy, which is probably your deep capillary plexus getting preferentially blocked, where the superficial capillary plexus recovered. And you can see it looks like, we saw the retinal artery occlusion was very white. This is a branch artery occlusion, but it's kind of grayish. And that's what you see in PN patients.
Those capillaries have some practical applications. The last time I saw a patient with retinal whitening inferior to the disc, and it was sort of obscuring the vessel just a little bit, and I was like, man, is that cotton wool spot? Although I really wanted to call it commotio. And there's no nerve fiber capillaries there now, and so it can't be cotton wool spots. So these are just commotio.
Yeah, probably. Yeah, because it's probably at the edge of the nerve fibers. So that's all the capillary networks. So then we're going backwards. So we did vitreous, retina, go to the RP, which is there's a lot on the RP. So the RP is a monolayer of cells. It absorbs light. It's got several functions, but it absorbs light. There's about 7 million. It goes down when you get older, so it probably goes from 7 down to about 3 or 4. They phagocytose billions of outer segments in their lifetime. So your RPE cells the retinal cells cannot divide. So when you lose a retinal cell, you don't get it back. So anyway, the RPE cells, so the rods shed mostly at dawn. Your cones shed mostly at dusk, which is sort of when you're done using them. And the other thing about the RP cells, it's the blood retinal barrier. It's like super important, especially for first years. Brooks membrane is not the blood retinal barrier. The outer blood retinal barrier is the tight junctions between RPE cells. It maintains the subretinal space, and they also heal and form scar tissue. That's out of your book. If you look at the RPE cells, melanocytes are really scattered throughout the RP cells, but the mitochondria are mostly in the base of the RP cells, and the phagosomes, which is the phagocytized outer segments are mostly superficial, and that's probably the two bright outer bands you see on the OCT. So we used to say that this was the brighter band, the interdigitation zone in the base of the RPE, but that's probably not right. So and I don't know how you should answer that question if you could ask it, but the correct answer is probably the mitochondria are the very bright outer band, and the phagosome zone is the bright inner band, which makes some sense because you lose this if the RPE cells aren't phagocytizing anything, you lose that bright band. So in retinal detachment and whatnot. And it makes some sense if you look at them histologically because the mitochondria have all these folds in them, folded membranes which would be reflective. They almost look like reflectors. And the phagosomes also look like that because the cone outer segments have a sort of a mitochondria. The outer segments of the photoreceptors look like mitochondria. This is the RPE diseases, macular degeneration. We see all the time, and that's where your RPE aren't working well. This line right here, showing that is probably the basement membrane of your choriocapillaris. So you can see that sometimes on the high resolution scans. And then down to Brooks membrane. So Brooks membrane has 5 layers. The basement membrane of the RP, the inner collagenous zone, mineral-elastic layer, outer collagenous zone, and basement membrane of the endothelium of the choriocapillaris. I always have trouble remembering whether there's 2 collagenous zones or 2 elastic zones. The way you could remember it is Brooks has 5 letters, and the middle one's a vowel, which is so elastic. I don't know how good that is as a memorization thing. So there's 1 elastic layer, and the other one there's 2 of each. And it's not a barrier, it forms no barriers, but it can get diseased pathologically. So, there's Brooks membrane. So this is one of the diseases which is a classic Brooks membrane disease. Does anybody know what it is?
Angioid streaks.
Nice, it's quick. Angioid streaks. So this is a patient with angioid streaks. Brooks membrane becomes, the elastic layer actually becomes calcified. You get these cracks, which people have worked out. Somebody mentioned like a year or 2 ago in conference, why do they form the pattern they do? And it has to do with the physics of the eye, because it's tethered at the optic nerve, and then you tend to get these radiating cracks, and you can kind of see them, I don't know if you guys can see that, but that's a crack in Brooks membrane right there. They show up terribly on fluorescein, but very well on ICG, on a late ICG. Late ICG angioid streaks light up. And that's it for RP Brooks membrane. Not a lot on Brooks membrane. And this person has a neovascular membrane over here, which is very common in angioid streaks, but it's not foveal, so we just leave it alone. And then the choroid. The choroid's interesting. It's got very high blood flow. So the choriocapillaris is a single layer. The vessels all anastomose, they're fenestrated, so they leak. So they're not a blood retinal barrier. Fluid and stuff leaks out of them. The lumina are huge. They're 4 times the size of a regular capillary. And you can see them in the picture here. Like that's a gigantic, probably that's a big lumina of the choriocapillaris. And probably the reason it has such high flow is it both cools the RPE and takes care of the very active photoreceptors. So it's got to do both of those. The oxygen coming out of the eye is not very deoxygenated, so it's probably a lot of it's cooling. So if you look at the rest of your body, your venous blood's very dark around your eye. It's not that dark. And there's the choriocapillaris. And then you get your other, and this is an example of a leaky choriocapillaris where in a patient with central serous retinopathy. So you can see the choroid's thickened on the OCT. The autofluorescence shows that bright area where there's been chronic subretinal fluid. And then the ICG, which is where you look at the leakage from the choriocapillaris, which is on the right, shows an area that's leaking. And it's tricky. The ICG does leak out of the choroid capillaris some, but it shouldn't leak out as much as it is here. And so when you're going to treat someone for central serous, and now you see that at about 5 minutes. And I just learned that by trial and error. So if you're shooting an ICG for somebody with central serous that you want to do PDT to, the first images aren't that important. Actually, the 15-minute images are not that important, but the 5 or 10-minute ones are. Did you say that's fine? No, this is different. So then the rest of the choroidal stroma. So the choriocapillaris, the stroma of the choroid has a lot of pigment in it. It's vascularized. It's got fibroblasts, macrophages. It does have some lymphocytes and mast cells. And then there's the 2 layers, which I think you're going to need to know now because of OCTs. We didn't need to. Haller's layer has the larger vessels, and Sattler's layer is not so large. So it goes, Haller would be the deep ones with the big vessels, and Sattler's layer would be the middle ones with the not so deep layers. And then the veins all join together to exit your large vortex veins. There's 4 to 7 vortex veins. And again, that's the kind of junk I would put on a board question. Is how many vortex veins. And then the suprachoroidal space is the last layer. So the deep layer, you get your choroid capillaris, choroidal stroma, suprachoroidal space. That's about 30 microns. It's about there toward the bottom of the picture. And it's got a mixture of components from the choroid and sclera. But the interesting thing is and it carries the posterior ciliary arteries, but it's loose, and it gives you a little more give, so it can swell. So you can get suprachoroidal fluid, and it allows for a little bit of a buffer. Now the choroid attaches to the sclera at the scleral spur, which is way out in the periphery, at the vortex veins and at the optic nerve. So that's one of the reasons you get this pattern. No, I guess not. If you get a suprachoroidal hemorrhage, you'll notice on OCT it's not all, it loculates, and it loculates at the vortex veins. So just so you know. And then the sclera is the outer circle that holds the eye. It's collagen and elastin. It's thinnest behind the muscles, which you guys know that for trauma. That's like the only thing you need to know for trauma. Look beyond the muscles. It's thickest posterior to the limbus. It's permeable to molecules, so it allows fluid to leak from the eye through the sclera, and it's hydrophilic. And this is a picture I was looking for. So that shows you a patient with this is a patient with posterior uveal effusion, where there's thickening of the choroid, there's fluid under the retina, and then when you do the ultrasound, there's these loculated areas of swelling in the periphery. And so that's basic anatomy. It's not thrilling, but you need to know it. So vitreous, neurosensory retina, retinal thickening of the Brooks membrane, choroid, and sclera. Yes.
So you said the choroid is attached to the disc, so you direct that photo. So if you scanned over the disc there, would you see the choroid come
Yes,
back?
yeah, the choroid will be attached to the disc always. Everything's attached to the disc. So scleral, spleral vortex veins, and optic nerve are your choroidal firm attachments. And then next month we'll do image testing, which is diagnostic testing, which is the second chapter.